So dyspnea on exertion. The moment you say dyspnea on exertion, you're already thinking of some pulmonary cause or something of cardiac cause. It is not something that is not at rest. On exertion means it is something to do with the lung per se or with a cardiac problem. Okay. Anybody wants to make a spot diagnosis here? It's quite simple. It's not difficult at all.
Pulmonary hypertension.
Yeah, it looks like it is pulmonary hypertension. Actually, if you look at the blood vessels in the lung, somebody described this. No, it's interesting to look at the description. Yeah, come, sonographer.
This is a frontal chest radiograph. There is a soft tissue opacity seen in the right hilar region, not obscuring the right quarter of the heart.
What is that lesion? What is that structure? Sorry? So it's actually the pulmonary artery. For all practical purposes, the hilum is the pulmonary artery. So you can say that instead of going through all this and you get into trouble, what is silhouette sign? You can simply say that the right main pulmonary artery appears to be large. So sometimes you use the word appears to be, so when you magnify, it may not be a single pulmonary artery, but multiple arteries overlapping, and you say that the main pulmonary artery appears to be large. It is not a hilum, because when you mag, I see multiple vessels over. So mag for the hilum is very useful in differentiating a lymph node sitting there versus when there are multiple vessels overlapping. So the way I report it is the prominence of the hilum is due to overlap of multiple vascular structures. And you'll see it beautifully when you magnify. Yeah, it's so simple when you magnify. So you can say that the right hilum is prominent, or you can say that the right main pulmonary artery appears to be. Sometimes you have to say appears to be. Yeah, you appear to be a good boy. Doesn't mean a damn thing. So before you come to that main pulmonary artery, look at lung vasculature.
There is increase in the vascular markings in the right lower zone.
Okay, this is a woman, right? So all that lower zone stuff may be because of breast shadows. Elsewhere, what do you think? Anyone? Is it normal, less or more? So you can say that the vascular markings are more prominent than normal, and somebody will ask you whether it's artery or vein, and it's dichotomously branching. It is near the hilum, both near the hilum, and therefore you'll say that this is arterial markings. Venous markings will go below towards the left atrium, like you see in mitral valve disease. Arterial markings will go towards the hilum. So you can say the hila are prominent, the vascular markings are prominent. Then you cover the heart and you look at the peripheral vascular markings. Are they prominent or not prominent? If the peripheral vascular markings are also prominent, that usually means a left to right shunt with increased flow. Yeah? And when the peripheral vascular markings are less, it may mean two things: left to right shunt with reversal when there is pulmonary hypertension, or there is peripheral lung disease such as chronic obstructive airway disease with emphysema, where the central vascular markings are prominent and the peripheral vascular markings are pruned out and there is pulmonary hypertension. So what I am saying is that you can have pulmonary causes of something like this, you can have cardiac causes of something like this, and the last thing that you should always remember, irrespective of what's happening to the pulmonary vascular markings, is pulmonary valve stenosis with post-stenotic dilatation. When there is pulmonary valve stenosis or peri-valve stenosis with post-stenotic dilatation, the vascular markings in the lung are normal, increased, reduced. Which one? When there is a PS situation, like in tetralogy of Fallot, for example, they are decreased. But you remember that in an adult with PS, you can have something like this, and if the vascular markings are like shunt vascularity, it is not usually a PS-like situation. So shunt vascularity with prominence of the main pulmonary artery usually is pulmonary hypertension. That goes with right-sided cardiac events, and you see if there is right heart prominence. Yeah. So the right atrium is a little prominent, but the ventricle is not really prominent. Also remember that the sure way of looking at ventricular dilatation or enlargement is a lateral view. If you have biventricular enlargement, you cannot tell whether it's left ventricle or right ventricle. Whereas on the lateral view, you see right ventricle behind the sternum and the left ventricle over the vertebra, and it's easier to tell right and left ventricle on the lateral view. All of this is ancient history, yeah? Only in an exam, nobody does all of these things now. So if you come back to this X-ray, the striking thing is the striking thing is that the main pulmonary artery segment is prominent, right? So you have right ventricular outflow tract, you have the main pulmonary artery that goes into the right and goes into the left. So this is the area of the main pulmonary artery segment. Multiple causes for that: post-stenotic dilatation, in which case the pulmonary artery markings are less, left to right shunt with reversal, or a pulmonary disease which produces pulmonary hypertension. The latter two, you look at the vascular markings. I feel, I may be completely wrong, and maybe biased by the history, that the peripheral vascular markings are less. So I have a feeling that this patient has chronic lung disease, though she is only 33, and there is 43, whatever, and there is reversal of flow. And this pulmonary hypertension is secondary to a lung pathology. Yeah? So you can do the clinical exam and rule out heart disease. You can do an echo. You'll see right ventricular strain pattern, you'll see pulmonary hypertension, but you will not see a shunt pattern inside or extracardiac shunt. Yeah? What would you do next? So this patient has come with dyspnea on exertion. Why she should be in Tata Memorial Hospital, I don't know, but she has come for that. You do an HRCT of the lung. Yeah? Start off with an HRCT of the lung, and depending upon what you see there, now there are two ways to look at it, right? If you think it's primary lung pathology, you'll do a HRCT of the lung and follow up with the contrast CT of the pulmonary artery and of the lung. This may be pulmonary embolus, for example, which is producing pulmonary hypertension. Now, many of these patients are completely asymptomatic. They have this dyspnea on exertion and numerous pulmonary emboli, and this is also called subclinical. No other sign. And this is what I learned from chest physicians. Dyspnea on exertion in young women who have all sorts of clotting problems, right? In our country, it's it's not exactly genetic, it's very prevalent. What is the most common cause of arterial and especially venous thrombosis? Anyone? It's a sort of genetic thing in our society. Sorry? Anything else? Yeah, that's one possibility. Anything else? All that is coming later. Okay, so you ask your vascular people what is a very common problem which occurs in Indians and that can produce all sorts of arterial and especially mesenteric venous thrombosis. So one of the things that I'm looking at here is pulmonary thromboembolism. I mean, that's probably the highest on my list. Then chronic lung disease, and then the least of all and most unlikely is intrinsic pulmonary artery or cardiac disease. Okay. Do we have a CT of this? We don't, no? It's okay. Who's following up this is ASD with pulmonary hypertension? Somebody has labeled it like that, or do we know? Just check it out, no? Let's see what's happening.
So the markings will decrease in
Reversal of flow.
reversal of flow. The
Markings will start decreasing. I mean, then you have to follow up chronologically, and then you'll see that first is frank shunt vascularity, and when there is pulmonary hypertension, it is called as reversal of flow. So left to right shunt becomes a right to left shunt or neutralized shunt, and then you have decreased vascularity in the lung. That's something that you see on follow-up. So let me know what this turns out to be. Yeah, 23-year-old, 33-year-old woman with this is possible. I mean, ASD is a classic clinical situation in a middle-aged, in a young woman with a murmur and breathlessness could be ASD. Yeah. Okay, we'll stop here. And please let me know the follow-up on this one. Yeah. And when we meet next, I'll talk to structure in the